Good afternoon. So my name is Antoine Vieillard. I have the honor to discuss with you venous return, the physiology and the potential clinical applications. Initially, I was thinking to have some interaction with the audience. Actually, I think it will not be possible, so it will be more a usual lecture. And maybe if you have a key question, you may interrupt me and ask your question. So I do not have any conflict of interest for this lecture. So this is the agenda. I will just illustrate the determinants of the systemic venous return, the crucial role of the right ventricular function, the impact of the positive airway pressure, the key role of the resistance to venous return, and finally, how to combine the Guyton and the Starling law, the Guyton and the Starling curves, which is for me a really key point for your understanding of the systemic venous return. So what about first about the determinants? So this guy is Arthur Guyton. I think you know the name very well. And actually, he described this curve of the systemic venous return. On the y-axis, the venous return, and on the x-axis, the right atrial pressure. So each curve regards a different animals, different dogs. And you see that when the right atrial pressure increased, the systemic venous return decreased. And when you are at zero venous return, so I mean when the curve crosses the x-axis, it means that the right atrial pressure is equal to the mean systemic filling pressure. So this is the equation of the systemic venous return. You have a forward pressure, which is pushing the blood into the chest and the right heart. This is the mean systemic filling pressure. You have a backward pressure, which is the CVP, so the pressure inside the right heart. And this is the pressure gradient for the venous return. And you divide that by the resistance to venous return. So this is always the same equation, you know, the cardiac output or the systemic venous return equal a pressure gradient times the resistance to flow. So what is the mean systemic filling pressure? The same guy just explained and reported here in this study what it is. And actually, this is still dogs, and he induced ventricular fibrillation, so the heart stopped beating. And you see that this is finally the equilibrium pressure between the venous part here and the arterial part here and the venous part here. So this is this point. When the heart stops beating, you have a pressure inside the system, which is called the mean systemic filling pressure, and which is really key to push once again the blood into the chest and into the right heart. So it is defined as the pressure generated by the elastic recoil in the overall circulation, so systemic and venous, arterial and venous during a no-flow state. Just look at what we try to do in this study. So we took more than 200 patients who had inserted catheters, so radial and central venous line, and in whom we had an expected death because of limitation of care for any reasons. And what we did that just when they died, we just recorded the pressure in the venous part and the arterial part. And you see that after 1 minute, we were able to measure this equilibrium pressure, which could be the 1 minute mean systemic filling pressure. And it was, the mean value was around between 12 and 13 millimeters of mercury. And just to go back to the landmark study by Arthur Guyton, in the animals, this was around 8 to 10 millimeters of mercury. So if you have to remind, let's say a normal value could be around 10 millimeters of mercury. So what is important is that this pressure is generated by two different things. The first one is the property of the container, so the property of the circulation on the arterial tree, but also on the venous tree. And the second point, of course, is the amount of blood inside the circulation, and especially what we call the stressed volume, the volume which is able to generate the pressure, and not just to open the vessel. So look at, for instance, what is this stressed volume. So it was reported by Sheldon McDare in 1998. So it's also a very high study, but it was not in animals, it was in patients. So look at, just to illustrate, the unstressed volume. The unstressed volume does not generate any pressure, just open the vein or the artery. The stressed volume is the volume that you add more and that can generate now the pressure, which is the mean systemic filling pressure. And just to show you the normal value of the stressed volume, it was here in this study reported around 30% of the total predicted blood volume. So it means that 70% does not generate any pressure and does not count to promote the systemic venous return. This is just a reservoir of blood, but which do not generate any pressure and any systemic venous return. So still, Guyton, you have two options if you want to increase the mean systemic filling pressure and so to increase the systemic venous return to improve the hemodynamics. Either you infuse a vasoconstrictor. Here it's not a pure vasoconstrictor. They infuse epinephrine in the animals. And you see that when they infuse the epinephrine along the dose, they were able to increase the mean systemic filling pressure. So this is the first option. You act on the property of the circulation. The second option is that you act on the amount of blood, and so you give more blood here to the animals. And something especially interesting in this study is that look at during fluid expansion, they reported a peak, a very fast peak of increasing mean systemic filling pressure, so increased systemic venous return. But look at along the time, it goes down, not at the baseline, but probably reflecting the fact that when you fill your patients, at the end, you have some leakage into the interstitium, and so a decrease in the mean systemic filling pressure, and so you go back to the baseline. Could be explained that we need to fill and to fill and to fill our patients, and at the end, we have a huge fluid overload with many fluids into the interstitium and not into the circulation and the chest. Look at here in animals still, just to show the effect of decreasing the vascular motor, the tone, the vascular tone of the circulation, so improving the systemic venous return. Here, this is in pig. This is an hemorrhagic shock model. And here, this is the IVC flow by ultrasonography, just to look at the flow coming through, passing through the IVC, so the systemic venous return. Just look at here the hemorrhagia before norepinephrine, and just infusing norepinephrine, the flow coming through the IVC was increased. So just by infusing norepinephrine, they increased the systemic venous return. And this is something that we usually forget, especially when we take in care our septic shock patients. We usually consider that to increase the systemic venous return, you need to more fill our patients, while many times, just by infusing norepinephrine, we restore the systemic venous return also with this, through this mechanism. What about the impact of positive airway pressure and the role of RV function on the systemic venous return? Just to show you this study I don't want to describe at all the model, the experimental model of this study, quite complicated, so in animal stills, but just to show you that what they did in this study is that they were able to modify the right atrial pressure by two different ways. The first, by modifying the pump, the extracorporeal pump. So maybe they were able to mimic some RV failure if they were decreasing the pump, and so the right atrial pressure increased. Or by another way, just to apply a positive airway pressure, and so just by transmission, they were able to increase the right atrial pressure. In both cases, you can see that they observed immediately and very quickly a modification in the systemic venous return with a decrease in the systemic venous return. Just this slide is really important before moving on. I just want to re-emphasize or to insist on the difference between two different right atrial pressure or CVP. The first one could be the intravascular pressure. So this is the pressure you measure here on the monitor relative to the atmosphere. to the atmospheric pressure. So the number of the monitor is the intravascular pressure. But you have another pressure which is really key, which is the distoning pressure, the transmural pressure. And this pressure is calculated as the pressure inside, which is the intravascular pressure, minus the surrounding pressure, which is usually the intrathoracic pressure, but in some condition, you know, as in case of cardiac tamponade, could be the pericardial pressure. And so this transmural pressure is quite related to the volume of blood into the right atrium, which is absolutely not the case of this one. And I will show you, especially for mechanical ventilation, you have a dissociation between both, explaining the limitation we have to understand exactly at the bedside with the invasive hemodynamics what happens. Look at, for instance, here, this patient, you have the esophageal pressure, just a surrogate of the intrathoracic pressure, the airway pressure with the peak and the plateau, and the right atrial pressure. The intravascular right atrial pressure, so on the monitor. The value at end expiration and the value at end insufflation. So it increased just by the transmission of the positive intrathoracic pressure. So that's difficult to have any conclusion from this tracing if you do not have the esophageal pressure. Because now you are able to calculate the distoning pressure, the transmural pressure of the right atrium, this red arrow in end expiration, this one at end inflation. So now much lower blood into the right atrium. So thanks to this, let's say, esophageal pressure, this surrogate of the intrathoracic pressure, you are able to understand that now, because of the transmitted pressure, we decreased the systemic venous return and we had less blood into the right atrium and into the right heart. Another thing, and it could be also related to the RV function, because you understand that the role of the RV is mostly to maintain as low as possible the right atrial pressure to promote the systemic venous return. But the right ventricle is very sensitive to any fluid overload, and this is also a key message of this presentation. You have here the inflow and the outflow of the right ventricle. So what they did, Starling and Patterson, these two guys on the top right, that they feel and they feel and they feel the heart, the right heart of the animals, and they recorded the inflow, so the flow coming into the right heart, and the outflow, the flow going up into the pulmonary circulation. And it was plotted against the right atrial pressure. And that's interesting to see that until a certain point, you may, let's say, continue to feel, you will increase the RV stroke volume without generating high increase in the right atrial pressure. But look at after a certain point, you increase a lot the right atrial pressure, and even in some dogs at the very right, you decrease the inflow and the outflow. So just by giving too much fluids, they were able to induce, to promote right ventricular failure, and so to decrease the systemic venous return. Just look at, this is something that you may observe in patients ventilated, for instance, with acute respiratory distress syndrome. This is so exactly the same recording than the previous one. You have still the esophageal pressure, the airway pressure, the right atrial pressure. Look at now the right atrial pressure, intravascular right atrial pressure in end expiration at end inspiration. So it also increased. But look at now the transmural pressure. The transmural pressure increased during inflation compared to the expiration. So now you are more blood into the right heart because the ventilation was promoting some RV failure and some obstruction at the ejection. So in this case, the intravascular and the transmural pressure, they are in a good alignment. They are moving in the same direction, while in the previous slide I show you, there was a dissociation between the intravascular and the transmural right atrial pressure. But also here, the systemic venous return is decreased because the right atrial pressure is increased. So you understand that you have two different options to increase the right atrial pressure, either by the transmission, of pressure during TADI ventilation, or sometimes due to the RV failure. In the first case, this is only the intravascular pressure which is increased, but the distoning pressure is decreased. In the second case, both pressures are increased during TADI ventilation. Look at, for instance, you see here, about the role of RV function. This is another situation which is comparing a change in cardiac output and right atrial pressure during exercise in two different populations, healthy volunteers here and patients after heart transplantation here. So first of all, after heart transplantation, they cannot reach a cardiac output as high as the healthy volunteers are able to generate. But second information, the price to pay was an increase in the right atrial pressure, so some failing in the right ventricle during the exercise. Just to show you also once again that sometime using the echo, you may visualize very well that the TADI ventilation may induce RV failure and so decreasing the systemic venous return. Just look at this is the left ventricle, the right ventricle, and here the left ventricle and the right ventricle. The wall in between is the interventricular septum. You have in green the airway pressure trace, so you just have a look during each TADI ventilation. And during each TADI ventilation, we were able to observe in this patient a significant dilation of the right ventricle, which is just reflected, as I show you, by the increase in the transmural right atrial pressure. So what about the key role of the resistance to venous return? Just to show you that things are a little bit complicated. So if you remember now, I told you that one key parameter of the systemic venous return is the pressure gradient for the systemic venous return, so which is the mean systemic filling pressure minus the intravascular CVP, or right atrial pressure. However, for instance here, what they did, the authors, they did a PEEP trial, so they increased the PEEP from 5 centimeters of water here to 10 centimeters of water. And they just had a look, it was in animals, so everything is possible in animals. They had a look on the mean systemic filling pressure in the two conditions. And just look what they reported is that the mean systemic filling pressure also increased by applying an intrathoracic positive pressure. So it is also transmitted to this mean systemic filling pressure. So something probably else could explain the decrease in the systemic venous return, not only the reduction of the pressure gradient for the venous return. Just to show you another study we did with the same, in the same kind of patients with expected death, just to show you that they were all ventilated with a PEEP, with an arterial line and a central venous line. And so just after they died, we just look at the pressure on the right, on the venous side and on the systemic side during inflation versus expiration. And you can see that there is some transmission. This is well the mean systemic filling pressure, but it increased during the inflation. And we were also able to remove the PEEP before disconnecting the patient from the ventilator. And the PEEP was also responsible for a slight increase compared to ZIP of the mean systemic filling pressure. Look at, for instance, here, you have a trace of the venous pressure and arterial pressure with the esophageal pressure. So this is the inflation and the expiration. And you observe some increase in both pressure just by the transmission of pressure. So some things are probably a little bit more complicated than I told you. And indeed this is, but this is not really new. It was published in 1992 by Nanas and McDare. So just once again, this is a model of PEEP trial, so increasing the PEEP from 0 to 20 centimeters of water. And they recorded the different parameters. So the first one is the CVP, the intravascular CVP, and as expected, the intravascular CVP increased along the PEEP trial. So this is just the transmission of pressure. They were able to report the mean systemic filling pressure, and surprisingly, as I told you, the mean systemic filling pressure also increased during the PEEP trial, and from the same level than the increase in the CVP, which is that at the end, the driving pressure for the systemic venous return was remained constant between all conditions, while the cardiac output and the systemic venous return well decreased. So probably something occurs, and the explanation of the authors was that we have baroreceptor on the chest, and when the baroreceptor felt some increase in pressure, they may induce a sympathetic activation, so increasing the venous tone, so increasing the mean systemic filling pressure to try to maintain constant the systemic venous return and the cardiac output. But it works not so well, and the price to pay is by definition that the resistance to venous return increase significantly, and at the end you have still a decrease in the systemic venous return and cardiac output. So you have this kind of adaptation, but the price to pay is that now the resistance to flow is much higher. And this is something that you can visualize, the resistance to flow. Here, for instance, in patient after cardiac surgery, you have the airway pressure trace. And what they calculated here, this is the transmural pressure of the supravena cava, which is a great vessel between, let's say, the periphery and the right atrium, so across which the flow is moving. And you can see that during each TADI ventilation, this transmural pressure of the supravena cava dropped very significantly, probably reflecting some collapse and so some increase in the resistance to flow. And just to show you something that you may observe by TEE, this is the supravena cava here and here. There is no respiratory variation, and there is no change here in the RV stroke volume. This patient was in the operating room to exclude, liver metastasis. Okay, and so for that the surgeon needs to do a vascular exclusion, so to cross-clamp the IVC. And so now this is something like the model of relative hypovolemia. The blood volume remains constant, but you have less blood into the chest and more blood outside the chest before the surgeon cross-clamp the IVC. And look at now after the cross-clamping, we were able in the same patient to observe this kind of collapse, so some increase in the resistance to venous return during each TADI ventilation, with some consequence in terms of RV stroke volume. And look at the blood pressure, so the patient was not probably 100% optimized before the surgery because the hemodynamics was not correctly optimized before the cross-clamping. Just something you can also observe indeed in a patient with septic shock here, but now not with relative hypovolemia, with absolute hypovolemia. So before fluid resuscitation, the patient is just admitted, still hypovolemic, and you have this kind of collapse, cyclic collapse due to the respiration. And now after fluid expansion, this is much better. And here in this patient, we were able to increase the systemic venous return just by giving a little bit more fluids to the patient. Just to conclude, how to combine the Guyton curve and the Starling curve. So I think that very frequently you see this kind of Guyton curve, as I show you initially. So the right atrial pressure increase, the systemic venous return decrease. But you also have in the books or in the papers this kind of Starling curve, which is that when the right atrial pressure increase, the cardiac output and so the systemic venous return increase. And so there are some contradictions, some opposition between both. Here it increase, it decrease, and here it increase, it increase. So something curious. And if you look at in the different books, physiological books, usually people propose just to superimpose the two curves, and they explain that the heart is moving from the crossing of the two curves to another crossing and so on, according to the management you apply, just giving fluids, just giving norepinephrine and so on. And actually, it was the case in the landmark study of Guyton. This is exactly what he proposed in his study, but we all forgotten that in this study, the chest of the animals was open. And so the surrounding pressure of the right atrial pressure was not the intrathoracic pressure, but the atmospheric pressure. So in this condition, and I go back to my previous slide, the intravascular pressure that you measure on the monitor and the transmural pressure that you may calculate by subtracting the surrounding pressure are equal. So indeed, you may superimpose the two curves. But in patients, when the chest is closed, you do not have the same value on the x-axis. So you cannot really superimpose the two curves. And so how does it work? And I go back to my previous slides. So here, during inflation, for instance, we increase the intravascular pressure, CVP. And so Guyton say that we decrease the systemic venous return. And so as we decrease the systemic venous return, indeed, as I told you, we decrease the transmural pressure of the right atrium. And so Starling says that because we decrease the right atrial pressure, we decrease the systemic venous return and the cardiac output. So please, I think, do not superimpose the two curves. Just use it differently. You increase the CVP, intravascular, you decrease the systemic venous return. Because you decrease the systemic venous return, there is less blood in the heart, so the distoning pressure of the right atrium decreased, so the cardiac output and the systemic venous return decrease. This is a Starling curve. And so Guyton is more focusing on the intravascular pressure, Starling more focusing on the distoning pressure. Just to show you, it was another example to understand the dissociation between both pressures. So it's not here mechanical ventilation. This is cardiac tamponade. So it's a patient that we drain at the bedside for cardiac tamponade. So very quickly, because he was in a very bad shape. So OD, this is the intravascular CVP, because we were just able to measure the pressure after putting also P, this is the pericardial pressure. So OD, this is once again the CVP on the monitor, intravascular CVP. And P, this is the pressure inside the pericardium. Just before removing the fluids, we were able just to measure the pressure into the pericardium. And you see that here the intravascular CVP is very high, but the transmural CVP is at least nil. And this is exactly why in the cardiac tamponade, patients are in a very bad shape. There is at least no blood into the right heart, and so no systemic venous return and no RV ejection. And look at along the fluid removal, you may observe that the intravascular right atrial pressure decreased, but the patient was much better because at the end the pericardial pressure was in a normal range, which is negative as the intrathoracic pressure. And now, indeed, the patient has much more blood into the cavity because now we were able to generate a normal systemic venous return. And I think this is my slide of conclusion. Systemic venous return, so, is mediated by the mean systemic filling pressure, the right atrial pressure, or the CVP. This is the same, and the resistance to venous return. The mean systemic filling pressure is generated by the stressed volume, which is around 30% of the total predicted blood volume of the body. The airway pressure is transmitted to the mean systemic filling pressure, but the increase in the resistance to venous return that you may look at by visualizing the respiratory variation of the SVC may act. And so for increasing the systemic venous return, you have two options. Either you give more blood. It's not very scientific to say that. Everyone knows that. But mostly, and this is the interesting point, when you have an absolute hypovolemia. If you have a relative hypovolemia, as we may have also in septic shock because of venodilatation, just infuse norepinephrine, and so it could support a more restrictive approach of fluid management in this kind of patient. You will be also able to increase the systemic venous return. You may also maybe decrease the airway pressure, so do not apply too high PEEP, maybe not to promote RV failure or not to promote too much pressure transmission to the right atrium. And of course, maintain or correct the RV function as much as possible, which is definitively key, much more than the left ventricle, to understand how to deal and how to play with fluids in our patient. Do not superimpose, please, the Guyton curve, which is mediated by the intravascular CVP, and the Starling curve, which is mediated by the transmural CVP. And thank you for your attention. I don't know if we have time for questions, but